Thanks for coming today. So today's talk is on spirometry, a topic that almost everybody in attendance is very, very familiar with. If you've seen the agenda for the continuing education series for this year, one thing you'll notice is that we really kind of focused on the basics. For the first 4 lectures, we're going to be covering spirometry, lung volumes, diffusing capacity, and 6-minute walk test. And the reason for this, you might go, this stuff we do all day, why do we need to hear about this? Well, it's because you do it every day that you need to hear about this. What we've seen in the last few years is we've had a period of very rapid growth. And as a result, a lot of seasoned veterans moved to the regional operations, and there's a lot of new folks here. And the training process here that worked for a small operation we're seeing is not working as well for a large operation. So we're rebooting both the initial training and we're instituting assessment of competencies, as I mentioned in a previous talk, our last business meeting. So just an overview of the talk today. I think I just lasered somebody's eyes there, sorry about that. So the talk today is to kind of review the most recent, now 11 years old, ATS ERS standards for spirometry. That is the recommendations for a standard technique. And hopefully reviewing that will enhance your understanding of spirometry. We'll be looking at some things like normal, obstructed, and restricted spirometries. Whoops, sorry about that. We'll talk about error recognition and review a little bit of the terminology that you use when you're talking about spirometry. By error recognition, I'm talking about errors that patients do when they're first attempting to do the procedure. These are the things that take so much time and effort on your part to try and get patients to do these techniques in a standardized fashion so that we know that not only are those results comparable or are able to be compared to what's considered to be normal, but they'll have comparability from one patient visit to the next, regardless of site. We're now in this era where we're seeing a lot of patients who are maybe first seen out at the satellites, then brought to the main campus for whatever reason, maybe a diagnostic procedure, and then they're seen on follow-up at the family health centers again. It really is not a good idea to have recognizable differences in the results that you would get from one testing station to the next or one testing site to the next that are not attributable to the patient. We want those changes to really reflect that patient's status. And then we'll be talking about some solutions, and by that I mean some of the common problems that occur during testing, and there are some simple solutions and there's some that aren't so simple. And those of you at the regional hospitals, we'll be covering some things today that may be new to you, and whenever possible I'll try to highlight those for you. So there's general considerations for lung function testing. That is a paper that was published by the ACCP, American College of Chest Physicians, and ATS Joint Committee on Pulmonary Nomenclature. And I just wanted to make sure that we're all speaking the same language. Boy, I keep hitting the wrong button here, folks. So I've just highlighted the first term, accuracy. Then there's the terms repeatability and reproducibility. We'll talk about measurement ranges and equipment resolution. So accuracy, let's talk about that. That's when you take a signal where you know what the result should be. And you introduce that signal into your measuring device and you see how close you came to it. And so if you came close or exactly on the number you expected to see, then you can characterize that device as measuring accurately. This is what we do during calibration. This is what we do in the morning. Now it's not quite that simple, as those of you that are calibrating know. We're calibrating both inspiratory and expiratory volumes, and we're doing it over several ranges of flows that simulate what the patient would be doing perhaps at the start of the maneuver, the forced vital capacity maneuver, where there's very high flows, and also very low flows that we see at the tail end of the forced exhalation, when the patient's almost empty and flows are very low. And also for other tests, body plethysmography is most notable. So not only do we want to be sure that we're measuring accurately, but we want to make sure that we're measuring accurately over a variety of clinically encountered flows, and expiration matches inspiration. And those of you that do lung volumes know what happens when they don't. Repeatability, highlighted in red on the slide here. This replaces the term reproducibility. We used to walk around saying, oh, you know, that was a good testing session. You know, it met all the standards and the results were reproducible. And that actually was a little bit inaccurate. Repeatability is the term that we should be using when we're talking about same testing session, same device, same patient, same operator. In other words, all of the same measuring conditions. So when we're talking about what's happening within a single testing session, within that context, we're talking about the repeatability of the results. And that's what our ATS comment, or the standard comment that we place on the test when all of the acceptability and repeatability of FVC and FEV1, when all those criteria are met, there's a standard canned phrase. And I'll be talking about technician comments and their importance and how we need to sort of tighten up how we do that in just a little bit. The term reproducibility, the old term that we used to use a lot, refers to measurements made over different conditions. This is basically, when you're talking about different conditions, the most common thing is when a patient comes here at one point in time and then comes here at another point in time. But in our instance, as we just discussed, we're really talking about changes in location as well. And from our perspective, we want to see reproducible results in the biological control arena. That's kind of our way of saying that, yeah, these are all calibrated. We know all the instruments are calibrated, but everybody in this room has probably seen instances where a device that was calibrated yielded slightly different or sometimes grossly different results than what was expected. That's the reason for our biocontrol program. We'll talk about more about that in just a little bit. So, some safety considerations. The ATS ERS statements made one very, very strong statement about spirometry testing, that it shouldn't be done within a month of a myocardial infarction. And in just a moment, I'll show you some of the things that we consider may not make the test as safe or the results as accurate as you would like it to be. ATS does allow for this test to be done in a standing position as well, but clearly, from my perspective, from a safety perspective, sitting is where we want to go. We really don't want the patient standing. We've done it under some very, very unusual circumstances, but, and we'll talk about this later, spirometry carries an attendant risk of syncope or near syncope, and in that condition, the patient can become unstable. If they're standing, then they're a fall risk. Really don't want that. So, conditions where you might get less than optimal test results. And this kind of cracked me up a little bit. Stress incontinence. Generally, we usually get good results. It's just what happens afterwards that's not so great. But dementia or confused state, oral or facial pain exacerbated by a mouthpiece, chest or abdominal pain of any cause. And as you look around the room, there's some smiles because we get patients sent to us all the time with every one of those conditions. How often do we see somebody who's here for open heart surgery, who has had all of their teeth extracted from dentistry, and then we're routed to us for a spirometry test? That definitely is not a great situation. Most of the time we really defer that patient to be tested at a later date when their mouth is not packed with gauze. But there are some other conditions that can affect the validity of the results or pose a relative danger to the patient. Hemoptysis of unknown origin, recent pneumothorax, unstable cardiovascular status, thoracic, abdominal, or cerebral aneurysms, and recent eye surgery. So these are all showing up in a document that I passed out to you by email just a couple of weeks ago. And the evidence for a lot of this is not great, but it is something that we want to raise your awareness of this so that you can make a judgment or make an assessment to see whether or not this patient might not be the best time to test a patient. If they recently had retinal surgery, for example, we really don't want to undo an ophthalmic surgeon's work by having that patient do a forced vital capacity maneuver. Now, the evidence that that could occur is more theoretical than actually documented, but you folks have brought these kind of things to my attention, and in some cases we have contacted the ophthalmologist or whoever it was that did the surgery and said, you know, what do you think? Is it okay to do this now? And in some cases we've got a green light. In other cases they said, well, let's defer till later. We really don't need this right now. Let's wait until there's been more chance to heal. We've also seen patients in just about every one of those other categories. We've had patients sent down to us with chest tubes because they had a pneumothorax the day before. In most cases like that, the clinical question being asked really did somewhat justify their writing the order, but those circumstances those circumstances really do require getting some feedback. Somebody, if everybody could mute your lines, please. Yes?
Yeah, so if everybody can please mute their line, and we'll see if that helps.
Okay.
Hello.
This will drive home your points.
Yeah, right.
Check.
Rats.
Let's see if the volume helps.
It's kind of strange. It just started happening. Yeah, hold on, folks. We're
We're gonna hold
gonna.
an audible and try a new phone. Should know by heart. 596. It's more impressive if I get that right.
After the tone, please record your name and then press pound. You are now joining the meeting.
Can everyone hear us okay?
That's
So,
All right, I'm gonna. Why? I think I know why. Hold on. All right. Now is there an echo now?
Yes. Did somebody come online?
That's a good thought. Is anybody who's online getting their audio online as well? Did somebody just join within the last couple of minutes?
We prefer you to dial in on a landline or a cell phone than through the computer if you're the culprit.
Hey, Daryl. Did you just join about 7:23?
It's just now. 7:23.
Oh, okay.
Where's Mike?
Well, how are you guys at listening through echoes?
Good.
All right.
We can hear you, but everybody's echoing, even people talking to us.
Jose, there's a guest at the bottom, 216-321-32. and it's saying that, guests using a device that's causing audio fouling or audio fouling.
All right.
What was that number again?
It's got like a yellow triangle. Okay, it's me.
Sharon,
I'm on the phone.
you're on a regular phone?
Yeah, I'm on a regular phone.
Could we ask you to disconnect and call back in?
Yeah, I'll move. Okay. Wow, that got better.
Well, she's fine, but we're not. Or are we?
Actually, we're better.
Yeah, we're better. I guess that was it. Thanks, Daryl.
That was Keith. Thank you, Keith.
Welcome here.
All right, Sharon, yeah. So if you can go ahead and mute your line now. And we'll see if this works. Sounds good. All right.
All right, so basically everything on this list is something you should be aware of that may cause either less than optimal results or pose a risk to the patient. And so we kind of take this as relative risks. These aren't contraindications. Again, basically everything on here we see on a regular basis. So other details, and there's an important one here. We know that the predicted values, the yardstick against which the patient's results are going to be compared, are dependent upon accurate entering of the patient's gender, to a lesser degree their ethnicity, to a major degree their age and their height. Weight is presented. That's a useful for the interpreting physician to look at some patterns associated with obesity. But everything that's on the data entry screen, everything, including what's imported from Epic, needs to be reviewed with what you have as the source for truth. The height is always patient without their shoes. Never ask the patient their height. We all know guys are a couple inches taller than they really are. Probably a lot of women too, but guys mostly, definitely. And if you ask them how much heels do they have on there, how do they know how that impacts their height? You really need to get a good baseline measurement. And we've seen variances of 5 centimeters or more in some cases. So these can be incorrect because they were either asked to the patient, what is your height? They could be incorrect because they were misentered, fat finger syndrome. Or you could be taking it as truth from the previous visit. And so we see a lot of errors perpetuated from one visit to the next. And so you need to take the opportunity, and nobody's going to fault you for taking a little extra time to just, before you save the data that you've entered and imported into the data entry screen, double check your entries before you close it, before you save that data. Once you save it, you have started into play. You're basically saying, everything in here is accurate. We now know how to evaluate this patient's lung function, which we all know to be individual to that patient. So this is a really important point. You can do everything else perfectly, but if you make a male a female, then we're expecting less. The reference yardstick is much, much smaller than it would be for that individual. And so you might miss disease that reflects a low vital capacity. So we really do want, I think you guys do a pretty good job of this. I mean, if you had a hard time getting the subject to relax, you'd have a hard time doing this job. But as you know, patients come with a fair degree of anxiety about what's going on, maybe not for the PFTs, but maybe what else is going on in their life with respect to their health. And many of them actually have had bad experiences in pulmonary function laboratories where they either had syncope associated with the test that they're about to do, or they really felt poorly after the test because they came very close to syncope, or just found it very, very difficult to do in the past. And so that's one of the anxieties that you're going to try and deal with, and we'll talk about that in a little bit. So one of the things that, we're in a kind of a unique situation. We're the Cleveland Clinic Health System, Pulmonary Function Laboratories. And what's unique about that is, even though we started at the main campus and then grew to regional operations, the Family Health Center, medical office building labs, we also brought into the Cleveland Clinic Health System 8 different hospitals. Those hospitals worked independent from each other, and there's now, well, let's talk about 7 because Lakewood is closing. But each one of those laboratories had their own policies for how pulmonary function tests should be done. And that's not unusual. All across the country, if you surveyed different laboratories, you'd find that there were slight differences in what their policies and procedures were. In part because pulmonary function is not a very well-regulated industry. But now with the situation that we're in, when we say that we'd really like the results that we're getting to be portable, meaning independent of concern about where the test was done, we really want to adopt a uniform attitude and policy about how should we do things. Now, one of the things that we stopped doing here at the main campus a long time ago was asking patients to avoid the use of bronchodilators, to discontinue their medications. And when we used to do that, one of the things that we found was some patients really didn't tolerate that very well. I can recall several instances of patients phoning in to cancel their pulmonary function and doctor visits because they ended up in the ED the night before trying to comply with the instructions to withhold all inhaled bronchodilators, and at that time oral bronchodilators as well. And so at that time we said, you know, this really doesn't make sense. At one point in time, we used to think of spirometry before and after bronchodilator as, you know, assessing bronchodilator response was really key to making the correct diagnosis of the patient. And there was this goes back decades, folks. There was this thinking that, you know, really reversible bronchial spasm, that's asthma. And non-reversible bronchial spasm, oh, that's got to be chronic bronchitis or COPD. And the thinking along those lines has really evolved over the years to where we're using the test more for other purposes than saying, you know, this is key to making the diagnosis. There are other things that point you in the right direction as to what the diagnosis is. And I will acknowledge that at some point in time you do want the patient to be clean, off medication, and see what their bronchodilator response is, but more for that patient where you're really questioning whether asthma is present or not, and their lung function is really not all that bad. But to have a blanket policy where you say all patients withhold medication really ignores the fact that some of those patients are highly dependent upon continuing that regimen, and you really don't want to disrupt it. So if a physician within Cleveland Clinic Health System really does want that patient a baseline assessment without medications, then they have the option to instruct the patient to withhold their medications before the pulmonary function visit. And as you know, we query the patient about what bronchodilators they're using, and we record that in the technician comments. So that happens all the time. So right now, the test really isn't being used as much to assess a bronchodilator response, but more being used to see, well, with the current regimen, noting that, you know, last time they took their dose of such and such was this many hours before test or immediately before test, the question then becomes, well, how are they doing on that? Is their medication bronchodilation optimized? And so in that setting where they continue taking medications as prescribed, we give them an additional dose of a bronchodilator, really looking to see, you know, has it improved? And with the current dose of bronchodilators, which we'll cover in just a moment, if they haven't responded, then the answer is they're doing pretty good then. They probably are optimally treated. Other notations are loosing tight-fitting clothing. Oops, sorry. If you notice that the patient's chest appears to be constricted, I don't see this as being an issue that much anymore. We used to be instructed to try to take a look and see if somebody was wearing a girdle or a corset. I don't see that being used all that often, but if it is, that's something that you might want to consider asking the patient to go to the restroom and loosen. If it appears that they're having difficulty, or if they state they're having difficulty taking in a deep breath. Dentures are another thing. I think everybody in the room knows and would prefer to have dentures stay in place during pulmonary function testing. You really disrupt the normal architecture of the mouth and make it more difficult for the patient to make an airtight seal, certainly using the round standard pulmonary function filters that we use just for spirometry.
Kevin,
Yes,
can I expand on one point?
certainly, anytime.
So the point that Kevin made, the points on this slide are extremely important and just worth a little bit of an expansion. The question is the issue about holding bronchodilators. I agree with everything Kevin said, but the other instance where a patient might be instructed not to take their medicines before being tested, and it's a common one, is when people come to you already on multiple meds, you're seeing them for the first time, and you strongly suspect that they don't need those medications. So how do you prove that? You don't send them on those medicines and leave open the question, yeah, maybe they're normal because they're medicated. So in that setting, you would also instruct the patient, stay off the medicines. I can pretty well assure you it's safe to do so and test without. But that's, as Kevin said, a call made in the office prior to testing rather than a laboratory policy. But it's a pretty common one.
Thank you. That's an excellent point. I mean, I think we've all seen that there are patients who get labeled with a particular disease. For example, if you're in a certain age group, you have a history of smoking, and you're complaining of shortness of breath, and somebody doesn't get a breathing test, doesn't document the status of your lung function, it's pretty easy to say, I wonder if they have COPD. Let's try them on this inhaler. And then if they go back to that physician or see another physician, they've already got a label now. This is a COPD patient, they didn't do well with this, let's add this. And that sort of leads to the scenario that Dr. Pacherko just described. And that would be one instance where definitely the doctor would want to see how they're doing without all medications. But again, that's a sort of a single patient, doctor to patient kind of instruction before the PFT, sort of a special circumstance. We really wouldn't want to make withholding medication a standard for safety reasons. This is what the ATS-ERS suggests patients should do. And we don't put this on our patient instructions. I'm pretty sure it might be difficult to actually enforce, and it might take a little bit more time in obtaining the history. But these are things that we know can acutely affect lung function or the performance of the test. So 4 hours from alcohol, smoking, 30 minutes from vigorous exercise, restrictive clothing, and a large meal 2 hours before testing. Particularly in the patient group of COPD, particularly advanced COPD, you shouldn't have to worry about it too much. They tend to avoid large meals anyhow because it is uncomfortable. The diaphragms, if they are hyperinflated, the position of the diaphragm makes large meals uncomfortable to begin with. So then we get into what you folks do as far as testing. Collecting of ambient temperature and barometric pressure, that's the start of the day. We go around saying, hey, what are the atmospheric conditions? And we know that this is used to convert the measured volumes. The computer's going to do this for you when you do your collections, from ambient temperature and pressure conditions to what it would be in the lungs, what we call body temperature and pressure saturated with water vapor, so BTPS. So a technical detail, but an important one. Recall within the past year we had a body box. Again, fat finger syndrome, entering of ambient conditions. The barometric pressure was off by over 100 millimeters of mercury. So instead of 723, it was 623, something like that. Made a huge difference on the lung volumes that were measured. It was caught by a biological control before any testing, before any patients had been tested on that system. So again, that's the value of doing biological controls. This was a calibrated system, but unfortunately there was an error made in an entry of a key environmental parameter. The ATS-ERS does recommend that the time of day on repeat tests, serial tests, be comparable within a couple of hours of each other. That's not a scheduling consideration that's typically given, but there is some diurnal variation in lung function. This is one that we really don't worry about. Again, ATS-ERS recommendations, they probably feel obligated to cite everything that's been noted to affect lung function. It has been noted in some studies that equipment and operator differences do exist. And that's one of the things that, as I said before, we really try to minimize. We really don't want doctors saying, oh, you know, I think this guy would do well for surgery. I'm doing a pre-op clearance. Could you test him on system number 5? I know that gives higher results. That's not a good laboratory situation to be in. And so as far as operators go, we know it would be darn near impossible to schedule a patient visit with the same operator in this laboratory or any other. Many of you move from laboratory to laboratory to help us with our coverage. Hygiene and infection control. This gets a lot of emphasis, and for good reason. The pulmonary function laboratories can be places where patients make little additions to our environment by virtue of hand contact with seats or equipment that other patients are going to touch later on. And so we really do want to make sure that we're safe as well as we're keeping our patients safe. So hand washing on entering and leaving the room, or foam in, foam out, universal precautions, reusable items. Almost everything that we use in the laboratory is now reusable. And if something is in direct contact with mucosal surfaces, that item needs to be disinfected and sterilized, or if it's disposable, and that's preferable, discarded after each use.
Okay.
Yes?
Do you guys use the CF precautions that we've been starting to initiate upstairs?
Oh,
where
you
we
betcha.
Gown and glove?
Yeah, in addition to that, that room is no longer used for testing until a half hour has elapsed after that patient's departure. So yeah, it's been a significant change, that addition of that patient population to us, and the new standards are something that Jose and Dr. Dazenbrook and infection control went over to ensure that there wasn't going to be a deviation from site to site, 10th floor, 9th floor.
Thanks.
But great question. I appreciate your asking that. If we weren't doing that, if I said, huh?
What?
then we'd have a real cause for concern and a follow-up talk. So they do, ATS ERS does cover personnel qualifications, but this section is vague, and I think perhaps intentionally vague. I think they didn't try to say, oh, you must be a registered respiratory therapist, because they acknowledge that this kind of testing is being done, and sometimes quite successfully, by people who aren't respiratory therapists. And so there was a nod to that. They did recommend that people go through a NIOSH-approved spirometry training course. I think that's a good course. It's a 2.5-day intensive training course in spirometry. I think that it's based on some antiquated standards. They were developed at a time when volume displacement spirometers were the norm, prior to computerization of those systems. So a good part of that 2.5 days is spent learning how to hand measure and convert distances on a piece of paper to an FEV1 and an FVC, and manually convert that from ATPS to BTPS. In short, a lot of time is spent doing stuff that you'll never do again. The computer does it for you. So I wish there was a better course. I don't feel strongly that people that work in this laboratory would benefit from attending. It wouldn't hurt you, but you won't benefit that much from it.